Hey Kristen, this is the assimilation video for the RAAS system. Just FYI, I'm sick as a dog and I'm just coming off at 24, so might be a little rough, but we'll get her done. Terms to start off with is renin. It is produced by the kidneys. ADH is an anti-diuretic hormone, so this whole deal is going to be about retaining fluid. Not diuresis, getting rid of fluid. We're going to try to retain it all. The renin-angiotensin-aldosterone system, which is what I'm going into next, is what this whole video is about. Angiotensin 2 causes the release of aldosterone. It is also a potent vasoconstrictor. Angiotensin 2 is. And aldosterone is what pulls the sodium back in from the kidneys. It slows the excretion of sodium, pulls it back into the body. And where sodium goes, fluid goes, so that causes fluid resorption also, as well as fluid retention. As far as the RAAS system itself, renin is the first domino to fall, and that's really kind of how this whole system is once renin falls, angiotensin 1, angiotensin 2, aldosterone, everything like that, they just continue to fall after it. So it's just this big daisy chain of events. Renin is released by the kidneys. So why? Changes in blood pressure, blood flow, osmolarity, which is the concentration of the blood, concentration mainly of sodium, a little bit of potassium in the blood, and glomerular filtration rate in the kidneys. Any one of those, or all of them, would be really intense. Any one of those starts to change, and you're going to have renin released by the kidneys. They're going to sense that. Osmoreceptors, baroreceptors, volume receptors, and start to release the renin. Renin will convert angiotensinogen into angiotensin 1. Angiotensin 1 is converted into angiotensin 2 in the lungs. So as the person's breathing, hopefully, it's going to convert angiotensin 1 into angiotensin 2. Angiotensin 2 is the one that is the potent vasoconstrictor. That conversion is caused by the angiotensin converting enzyme, which is ACE. Kind of familiar sounding. Angiotensin 2, again, it stimulates sodium resorption by the kidneys, renal tubules. It also, over here, constricts renal vessels. And that one's kind of neat, because instead of just stimulating sodium to pull back in, it's also going to constrict those vessels. Because it knows if it lets the kidney have that blood, it's going to start to filter it out. It's going to start to take that sodium away, start to take the fluid away. So it's going to say, kidneys, you're not getting anything, and it's going to constrict those renal vessels just so that that flow isn't there, and therefore it cannot be filtered or anything like that. That way it can pull that fluid in, it can pull that sodium in, and try to raise the blood pressure and the fluid content of the systemic body. So less sodium is filtered out, more sodium is retained. Again, where sodium goes, fluid goes. Angiotensin 2, the potent vasoconstrictor, then stimulates the release of ADH, the anti-diuretic hormone, which we also call vasopressin. It increases sodium intake. Don't look at that. Increases sodium intake and excretes potassium, because another way that ADH can be stimulated to be released is a high potassium level. So again, changes in osmolarity. But it is going to pull sodium back into the body, kind of like everything else we've talked about, and it's going to get rid of that potassium. So it's going to change more with your chemical levels, electrolytes. So in an emergency, this process is going to help. It's good. When blood flow decreases, blood pressure decreases, osmolarity decreases, all that stuff that we just talked about, when any of that happens, this RAAS system is going to be stimulated. However, it is extremely slow. It's not going to save you on the side of the highway when you're all mashed up in a car or anything like that. But you would be able to see it in an ICU setting. Over the course of a couple days, you would see urine output level changes and stuff like that. You'd probably see serum level changes of sodium as the body is attempting to retain that fluid. It's just not anything we're going to see. Long term, can it help? Certainly. That's why the body does it. But it's just not going to be a real good acute fix by any means. And then I always like to look at what, if we have this, then what is the counterbalance of it? So inhibition of the RAAS system, I'm not really sure how to say that. Natriuretic proteins, I don't know. Sodium, essentially, proteins. And they inhibit ADH. And so if they inhibit ADH, if they inhibit antidiuresis, they're going to cause diuresis. So they increase excretion of sodium to decrease fluid levels in the body. So if the RAAS system kicked into overdrive for what it thought was going to be a big event, and then it really turns out that it wasn't, these natriuretic proteins are going to increase the excretion of sodium and start to balance things back out. So again, it's kind of a checks and balances. It's pretty cool.